Okay, hi everyone. So welcome back. So if you still have that anatomy coloring book, this is a good time to start using it if you haven't started already and doing the anatomy of the vessels. So the thing about with anatomy, and especially something like the vessels where there are a lot of these vessels, it's great to start as soon as possible and do repeated repetitions so that you can have a better idea of where these vessels are, because anatomy and just have when there are so many vessels in the body, just when you have that many things to identify, it's best to work on it early and often. So that's one thing you should definitely start working on and use that section of the anatomy coloring book. Again, it's not required for this class, but if you really liked it from last semester, you might want to use it again and crack it open. And you might see me including this. So another thing is that I am actually taking my own another course. So I'm always interested in improving my teaching and my video lectures as well. So other things like they love calling, other professor might call these learning objectives, and that's the thing with people who work in education. They love these like kind of like these business-like terms, and I'm just like, why not just call them goals or key points? So you will see me including these a lot more when I have time, but I'll try to do it. They are encouraging this because why? Well, think of this like a preview of a study guide, or when you're going through my lectures, these are why I'm kind of basing these lectures on. So it's like a lot of these, but when you're going through it, you're like, okay, do I know this enough? Like when you're looking at these statements, can I do these things I'm listing here? And there are different sections that are related to each of these points I'm talking about here. And if you're not quite sure, or you could use an additional explanation, you can always ask me or come to office hours as well. So I try to hit all of these in today's lecture, and I'll try to include these more. So they're kind of like a study guide in advance, because again, why do I include all of these? Well, these are important things that you will need, especially if you're going to the health professions. You'll definitely need to know all of these goals and key points. Alright, so before we start, so there's a lot of condos popping up here in Hawaii and just around the world. So if you live in a condo or apartment, how might living on a higher floor be hazardous to your health? You might think, I never thought of it, but yeah, there's something that related to the heart, why it can be bad in terms of your cardiac health. But before we get to that question, let's start with the question for today. What we have are this question right here. So there are 4 classically canonically accepted vital signs. There are some people who say there are 5 or 6 vital signs, but which are the commonly accepted 4 vital signs? So which of these? So the responses are, what did people say are the 4 vital signs? It looks like some of you said blood glucose, most of you said blood pressure. Body temperature is also popular, heart rate, and respiratory rate. And the correct ones are the most popular ones. So even though these are all important, in terms of the vital signs, these are the 4 canonically accepted vital signs. So there are other things involved, but oxygen saturation, very important and definitely something you should be paying attention to, but it's not always accepted in all institutions as a vital sign, curiously enough, even though oxygen is very important. Okay. Yeah, I know it sounds counterintuitive, but why do I bring this up? Well, this is why we have this over here. So if you look at this monitor, if you go to any hospital bed and you'll see modern hospital bed, you'll see one of these monitors. And on this monitor, you'll see various things like different numbers, different graphs. So this is why it's also important to know how to read a graph as well, but also know what these numbers are. And all the vital signs are here on this display right here. So what you were talking about with one of this heart rate is one of the vital signs, and that's what we'll be talking about today. And you might be looking, oh, what's this squiggly line? And you might already know what this is, but you probably have seen it at one point, especially if you watch TV or any sort of medical show or any sort of like a movie or TV show with something medical in it or someone in an emergency. So what that number over we saw up here is HR is the heart rate. So heart rate is so for this class we're going to establish this as the normal resting heart rate in adults. So according to the AHA and the National Institutes of Health here, it's 60 to 100 beats per minute. So we'll use that. So it's like music with beats per minute. The more beats per minute, the faster the piece of music. Same with heart rate. So the more beats per minute means that your heart is beating faster. It's cramming more of those heartbeats and cardiac cycles in 1 minute. Now this will be our reference range because I'll talk about abnormally high and low heart rates. And yes, age and health also affect heart rate as well. So our heart rate starts off faster when we're younger, and then as we age, it starts to drop as well. And so that's why am I going to ask you about what's the heart rate in newborns versus one in somebody in their 70s. Not in this class, but if you're going to nursing or medicine, you have to be more aware of that. And what we see in that squiggly line is a electrocardiogram or ECG or EKG. And was he Dutch? Like the guy who discovered it or started using these electrocardiograms, Einthoven. So this is why it was spelled EKG, because in that spelling of his native language, he is spelled with a K instead of a C. So you might see EKG, ECG, it refers to the same thing, but in terms of English spelling, we call it electrocardiogram. We don't use the K spelling. Now with this electrocardiogram, that's like a cartoon version, but if you've seen in a hospital, you might have seen these like paper printouts as well. Now what's happening is that you can actually take different types of locations on the body, can give you different graphs of this EKG, but what's it doing? It's measuring some sort of electrical activity in the heart. So that's why it's electrocardio, and then the gram means you're showing some sort of graph. Now here's the placement of ECG leads. Do I expect you to know that for this class? Not really, because again, that's something for ECG techs to do, and heck, if you're a doctor or a nurse, you might actually have a tech do it instead of you doing it yourself. But there are different landmarks. I don't expect you to know the landmarks for this class because we're just covering the basics, but if you do plan on, and that's also a career in itself, like just knowing where to place this, because they delegate all the roles. You can't have like a nurse or a doctor doing everything all at once. So often there's somebody who's there just to establish and put on these EKG or ECG leads when someone comes in and they need their heart looked at. So again, the heart is over there, and notice that the heart, some of these ECG leads are following that direction of the heart from the base to the apex. So you notice it's following that, going from here and traveling to the left. So that's a very important clue as well. And also, why? Because remember the conductive system? So the conducting system also depolarizes this way. So it also has goes from SA node to AV node down through the bundle of His, bundle branches, Purkinje fibers. So it goes from superior and down and toward the left. So that's why these leads are placed where they are. And there's also other leads. So if you were able to get them, your TA was able to get the machines to work in lab, what they might have done is like these kind of EKG leads where you don't have to take off any clothes, because again, you just have it here on your wrists and on your legs, but you can also move it up closer as well, because why? Your heart is over here. So sometimes you can also move those same leads closer and more proximal to the body. So again, closer to the trunk versus distal, but you can have them over here as well. But what it is that these detect electrical activity. So if we look in the body and look at action potentials, is like, remember that this is why I spent so much time talking about action potentials, is because remember that sodium and calcium flowing into these cardiomyocytes and conductive cells is very important in terms of not only signaling and triggering the contraction, but those are positive ions that end up inside the cell. So in this diagram, you notice that in a relaxed cell where there's not calcium flooding into the cell, you don't have remember, a resting cell has a negative membrane potential. So this is why it's showing like it has a negative charge inside the cell. But when you have sodium and calcium rushing in, then the inside of the cell gets a lot more positive, right? So this depolarization causes an overall or relative positive charge inside the cell. So the thing about those electrodes that feed into the EKG is that they're able to detect this positive charge. So if you have this depolarization and the inside of the cell becoming more positive, that causes the EKG to flick up. So that represents positive change in membrane potential. Now, is it measuring every single little cardiomyocyte? Not really. What it's actually doing is measuring the overall activity of a bunch of these millions of cardiomyocytes. Is it millions? I have to look up the number, but all these cardiomyocytes that are depolarizing, any that are depolarizing are going to flick up that that lead on an EKG. So this is what electrocardiogram is. So it is related to action potential, but this is why it's kind of different. It's not so much looking at individual cells, but what's the overall pattern of depolarization in the heart? So which chambers and which areas of the heart are depolarizing at once? And what we see here are three main, or not, actually like three main landmarks, but actually there are 5 different waves. So there's a P wave and the QRS complex. Now QRS because it goes down here, so Q goes down here, R goes up here, and then S down here, and then T wave over here. So there are 5 waves, but I usually refer to the QRS as one complex. Now you might be wondering, like, why is it PQRST? Well, this is the story I heard, and I think this is and every time I try to look up where they came up with it, it seems to be some variation of the story. Like the guy who discovered these waves, he chose a letter he thought was somewhere in the middle of the alphabet so that he could start there. And then he realized, like, hey, these waves, they repeat every 5 waves. So then they end up just being PQRST because every cardiac cycle you just generate the same waves. And there are also all these segments as well and intervals, but I think the intervals and segments are useful if you're going to nursing or medicine. But for now, I definitely want you to focus on, you gotta know where all the waves are. And this is why it's called a QRS complex over here, because notice that the Q wave, the R wave, and the S wave in a normal heart tend to be bunched closely together. Whereas the P wave and T wave, they're pretty distinct by themselves. Now, what we have here with the P wave is that with this diagram we're seeing is that the purple is representing depolarization. So in the previous slide we saw that depolarization, and with our action potential talks, remember that depolarization means that the cells are undoing their negative membrane potential. Why? Because again, all that calcium and sodium is rushing into them. So that depolarization is going to spread this way. Why? Because it's going from SA node along these internal pathways and down to the AV node. So what we have are all these positive charges, like these depolarizing cells that are becoming more positive, depolarizing, and it's spreading from the base and superior down here and inferior. So what this is detected as by this electrode over here, this positive electrode is going to detect this positive wave. So it's a small increase in this. Why? We have all these cells becoming more positive. But compared to the overall mass of the heart, notice that it's not the majority of the heart muscle. So it is a bunch of cells depolarizing at once and becoming positive, but not all of them. Now, this is why it goes that way, because again, remember that if we're talking about ventricular cardiomyocytes and the heart muscle cells, when they depolarize, their membrane potential goes up and becomes more positive, right? Same with the EKGs. So it's a different shape because it's the sum of all of these cells in these areas having this depolarization. Now, this is what it looks like in the other diagram. So we see, think of it like a wave of positive charge approaching this electrode. So when you have that wave, that causes that P wave as well. Now, over here, what we have is, remember that this conductive system, this is why it's important to know the sequence. It spreads from here to here and now along the bundle of His and along the branches. And this is also going to spread among the Purkinje fibers. So when that happens, we're going to get ventricular depolarization. And this is where we get the QRS complex. Now, what causes the Q and S waves and why does it dip down? I'll leave that for a future or your advanced classes as well. But what I want you to compare is the P and R wave. And what we see here is that the P wave, it has a pretty small amplitude, so a very small height. But compared to the height of the R wave, what happens is that you notice the R wave is super, super high compared to the P wave, right? So why is that? Well, if the atria depolarize, you only have these cells over here. That's why I'm trying to show with this small action potential. So you have all this depolarization, but relatively fewer compared to the huge meaty ventricles, right? So the ventricles full of cardiomyocytes, those heart muscle cells, and all these conducting cells as well. So when you have all of them depolarizing and causing these action potentials at once, this is going to cause a greater amplitude because there are a greater amount of cells that are depolarizing at once. And then what happens is like, okay, we contracted, depolarized, but now we have to repolarize and reset. So remember that with these action potentials, there's an upswing, that's the depolarization, but eventually you have to reset things and bring them back down to earth. That's repolarization. So notice that repolarization will bring it back down to the negative membrane potential. So what happens is with repolarization, at least in the ventricle, or like what happens with repolarization, it occurs in the opposite direction. So the interesting thing is that because notice that in the previous steps, depolarization went along the conductive system, right? So it went from here to here, so it's going down and toward the left. So it's going inferior and toward the left, but notice that repolarization is actually going upwards, so it's kind of backtracking. So what's happening here is that this would, so if it was going the same direction, it would end up going like this. But, so if this repolarization was occurring in this direction, from base to apex, it would look like this. But thing is that it's also going in the opposite direction, right? So it's kind of like a double negative. I know it sounds weird, but so repolarization is going to drop your membrane potential, and if repolarization went this way, it would look like this. But because repolarization goes in the opposite direction and it goes from here to here, it's actually going to flip it around. So this is why it looks like a positive deflection, because it's like having the negative of a negative number. If you take like, what's the negative of -1? Positive 1. Same with the EKG. Because repolarization reverses its direction and also has a drop in membrane potential, it ends up looking as positive on an EKG. I know it might be confusing at first, and it often confuses a lot for first-time learners. Even some med students, they're like, I just don't get it. But the way I think about it, I just think of it as a double negative. Like a double negative equals a positive. So that's kind of what's happening with the T wave. Now what's happening is like, so notice that the different parts of the T wave correspond to different parts of the cardiac cycle. So again, that P wave, when the atria depolarize, that causes the P wave, causing them to contract. And then when the ventricles depolarize, that activates all the ventricular cardiomyocytes, the heart muscle cells, causing them to contract. And then when they relax, that's what causes the T wave. And then when you have full atrial and ventricular relaxation, we can start the whole cycle over again. So this is why the 5 waves of the EKG repeat over and over again. Now, what is the relationship? So again, atrial diastole is when the atria, actually we have both atrial and ventricular diastole. So the P wave is when we initiate atrial systole. So again, why? The cells and the atria are depolarizing, so they're going to squeeze. So atrial systole starts with the P wave. And then the QRS complex, so what we have with that R wave, again, the R is representing all those ventricular cardiomyocytes depolarizing at once. So that's why it's the start of ventricular systole. And then we have this diastole occurring after the systole ends in both. But notice that the T wave is due to corresponds to the end of ventricular diastole. And why is that? Because the ventricles are now relaxing, now they're resetting. So their membrane potentials are becoming negative, but because it's in the opposite direction, it's going to be a double negative and end up going upwards. So this is an important thing, is like this, especially with, so this is why EKG is pretty powerful, because all you have to do is place these sensors on the skin of a patient and you can detect things that might be abnormal with their heart function or irregularities with that, and also look at how the timing of these systole and diastole and whether there might be something causing problems with their heart. Now, this is why EKG interpretation is very important, because again, it's like you don't have to actually poke anything into anybody or take any blood samples. You can just establish this readings on the skin. So this is why, now, do I expect you to know how to interpret any EKG? No, that actually takes years. Like even in med school, we tell them like it actually takes multiple years of experience to actually read a EKG. So what I want you to do is start with the basics, but this is why it's very important to know what EKG is, because it's measuring that health and electrical system of the heart, but also the overall functioning of the cells that are depolarizing in the heart as well. Now, this is one important thing you can get from an EKG is the heart rate, that first vital sign I'll talk to you about. So with heart rate is that we have all these QRS complexes, and what we have, so this is the way I measure it if I'm just have an EKG paper, and most machines will tell you how to do this, but this is how they derive that heart rate from an EKG. So what you can look like, you can't measure it from you theoretically could measure it from a P or T wave, but notice that the R wave typically tends to be sharp and pretty well defined. So if you're doing this manually and calculating the heart rate this way, what you can look at are the peaks of the R wave. So between peak to peak, this is a certain amount of time between each cardiac cycle. So when you have a standard EKG paper, the big boxes, so represented by these darker lines, these are 1/5 of a second, so 0.20 seconds. And so that means each 5 of these would be 1 second. And then notice that these big boxes are subdivided into smaller, fainter little boxes. So these are 0.04 seconds. So they're 1/5 of a big box, and a big box is 1/5 of a second. Now what you do is count the big box and little boxes, and now you know how much time there is between each R. So what we have here is like, okay, 4 big boxes plus 2 little boxes. So what we have is like, okay, 4 big boxes, so 0.2 times 4 is 0.8, and then we have 2 little boxes, so 0.04 times 2 is 0.08. So what we have is 0.88 seconds between each peak. Now, how do you convert that to heart rate? Well, remember heart rate is based on beats per minute, right? So we have to take what we have here is 1 beat, but we have seconds. So we have a unit of time, but we have to convert it to minutes. So what we have to do is that dimensional analysis, right? So what we have to do is convert seconds to beats per minute. And how do you do that? Well, just take how many seconds are in a minute, 60 seconds per minute. And what you do is do this, you just cancel out the seconds, and now you just take 60, divide by 0.88, and now you get 68 beats per minute. So that's how you go from an EKG to get your heart rate. Now, this is a nice way of the way I like to think about it is like you can actually derive this formula yourself if you like algebra. But what you can do is just take the number of big boxes between the QRS peaks, and then just take 300 divided by the number of big boxes, and that gives you your beats per minute. Now, how do you get that? So why is that useful? Well, say you have this EKG right here, and now you notice that there's 5 big boxes between each R wave, right? So you might think, oh wait, that's 1 second, right? So we have 1 beat per second. Oh, that's actually 60 beats per minute. But if you also use that, so what you can do is this formula, and then you can do 60 beats per minute. Or you can just do this. Beats per minute equals 300 divided by big boxes. So we have 5 big boxes, and 30 divided by 5 is 6, so 60 beats per minute. You get the same thing. So that's why it's like, I like that one because it's pretty simple. And the other thing is like, say we go from here to, we have that. And then how about this? Well, now we have 4 boxes. So what do we do? Well, you could do this. You could do the big box method. You could multiply the amount of seconds. You could put 1 beat over 8 seconds, do the dimensional stuff, and then change it to convert it to 7.5 beats per minute. But what about beats per minute that's using this formula? Well, 300 divided by 4, so let's just divide by 2 twice. So 300 divided by 2, 150. 150 divided by 2, what is that? That's 75, right? So this is why I like that formula, because it's really quick for me to calculate. But there's multiple ways to calculate this. This is the one that I find the easiest. How about this example? So 3 big boxes, and let's ask the chat. So how many beats per minute is this EKG right here? Alright, looks like most of you are saying 100 beats per minute. And yeah, so if you're using the traditional method, what you can do is like 0.6, 1 beat times 0.6, and then times 60. 60 divided by 0.6 is 100. How about this? 300 divided by 3. hopefully you don't need a calculator to do that. That is 100 beats per minute. So this is what we're seeing here. So notice that the fewer boxes, the faster the beats per minute, and that's why I also progress this way. So what we see is that, notice that between 3 and 5 boxes, so 5 boxes was 60 beats per minute, right? And 3 boxes is 100 beats per minute. So what's interesting is that what was that normal heart rate we were talking about? 60 to 100 beats per minute. So this is something I'm like, okay, is this heart rate too fast or too slow? I'm like, okay, is it between 3 and 5 boxes? If it's less than 3 or if it's greater than 5 boxes, then I'm like, okay, if it's less than 3, that's a really fast heartbeat. Or if it's like more than 5, I'm like, okay, this heartbeat is pretty slow. So this is why I think it's an easy way to kind of know at a glance whether a heart rate is pretty abnormally slow or fast. Now, there are things that can go wrong, so it's not just about beats per minute and heart rate. Heart rate is a very important vital sign, but remember that what is causing these EKG waves is due to electrical activity in the cells of your heart. Now, what can happen is that you can have different patterns that are abnormal compared to a standard EKG, which in a normal heart should just repeat regularly, showing the same shapes of waves. So what we see in this example is kind of interesting. What we notice is in this part right here, yeah, we have our P wave, we have a QRS complex, but in this over here, we notice that P wave and T wave are so close, they're almost running into each other. And that's what we call premature atrial contraction. So notice that this thing, the depolarization is kind of jumping the gun. That's why it's like really close after the T wave finishes compared to this interval over here. Now over here is what we see. Okay, we have our P wave, but as we go over here, we see like, is this a P wave? Is it a T wave? So these are P waves, but what we have here is something called paroxysmal atrial tachycardia, or PAT. So why is it atrial? Because we know that the P waves are caused by the atria, and it's not the QRS waves that are jumping the gun here. It's the P waves that are jumping the gun. So what we are seeing is that tachy is a prefix used to imply something is abnormally fast. So what we see is that the atria are abnormally fast and jumping the gun, that they're kind of running into each other. So they're kind of taking over that T wave as well. And paroxysmal, well, actually it's not exclusive to the cardiovascular system, but when you ever see that paroxysm, you think of it as like almost equivalent to like temporary. So you might have someone who has this kind of like temporary beats where their EKG might look like that, and then it might look normal like a few minutes later. Now what we have here is like, okay, are these P waves? Yeah, I guess so. So it's kind of a P waves, like these are P waves, but is there a real clear delineation between a P wave and a T wave? Yeah, so this is an unusual pattern we see here, but notice that the QRS complex. Do you think the QRS looks normal? Looks pretty normal to me, so it looks like the P waves are the culprit. So what we actually have here is something called atrial fibrillation. So fibrillation, think of it as something kind of like fibrillating is like, think of it kind of like twitching and fluttering, or actually I shouldn't say fluttering because atrial flutter is something slightly different. But fibrillation, think of it as kind of like twitching and kind of like seizing. So it's not really like it's kind of disorganized and kind of like bouncy and jittery. And that's what we're seeing with this atrial fibrillation. We're seeing P waves, but they're not really regular. And what is that going to do? Well, is that lethal? Not immediately. And the thing is that people can live with atrial fibrillation and maybe go years without knowing this. The atria are important in squeezing blood to the ventricles, but the ventricles actually fill more by that passive filling and that suction when they relax. So the atria help to move blood along, but when you have the atrial fibrillation, it's kind of like disorganized like this. The ejection of the atria are no longer contracting very organized and very rhythmically. So sometimes blood stays in there and kind of recirculates, and sometimes it also forms clots as well because it's kind of stagnant. So this is why sometimes these patients with AFib, this is another sometimes call it AFib. Sometimes you need to give them things that help to prevent clots because of that blood kind of stagnating and kind of staying trapped in the atria compared to a normal functioning heart. And then let's talk about the QRS complex and the T waves. Now, what we see here, okay, where do you think something is very strange? Yeah, these look pretty normal, but what's this big old dip here? So this is what we have is a premature ventricular contraction. So notice that this is the QRS complex, very huge, and again, QRS complex is when ventricles are depolarized. But now it's the ventricles that are jumping the gun. So it's jumping the gun and now kind of like bleeding into, like kind of ramming into the previous EKG and cardiac cycle. And yeah, so that's what we see with this PVC. The premature meaning it's jumping the gun with that. So notice that kind of obliterated the, is that P wave or T wave? Not quite sure. And notice that like it doesn't even really have the T wave in because it's like inverted in this aspect. Yeah, so is there a B, P, is there a T? It's kind of weird. So that's why ventricular contractions look a lot different than the premature atrial ones. And what we have here is something called, well, we do see that weird scoop here, but notice that the QRS complexes are like now compared to the previous example and the normal EKGs, now we don't even see P or T waves or a normal P or T wave between these QRS complexes. So this is something we call ventricular tachycardia. And why? Because tachy meaning fast, but now it's like so fast that we don't really see normal P or T waves anymore. We see QRS complexes, so now the ventricles are depolarizing at a very fast rate. So that means our blood is actually squirting at a real quick, or actually that means our ventricles are contracting at a very fast rate. And the interesting thing is that ventricular tachycardia, if you don't intervene in time, it can end up into something called ventricular fibrillation. So let's go back to our heart rate. So our normal adult resting heart rate is 60 to 100 beats per minute, at least for this class. And then what we have is that tachycardia is an abnormally high heart rate. So this is definitely something you should add to your vocabulary, especially if you're going to medicine, you gotta know this. And then the opposite is bradycardia. So you have an abnormally low heart rate below 60 beats per minute, at least for this one. Now these are common EKG or ECG abnormalities. I don't expect you, this is where like OpenStax, you may have noticed, sometimes it's really simple, sometimes it goes really in depth. And I'm like, wow, they are including second degree, third degree block. I don't expect you to understand or not to recognize second, third degree blocks at this stage. Like maybe even for med students, that's like kind of like a kind of advanced. So don't worry about second and third degree blocks over here. So what we have, but these over here, so the thing about ventricular tachycardia, it can lead to something called VFib or ventricular fibrillation. Alright, so let's go to our next top hat question. So this is a click on target. So we have an example of VFib, ventricular fibrillation. Click on any P wave. Alright, let's see where people clicked on. So kind of all over the place, right? And that is what VFib is. So it's a trick question. I'm not going to ask you this like this specifically on the exam. Like click on where's the P wave on a VFib. There is no P wave. It's kind of crazy. Like it's like what's happening here is that we have this mass amount of depolarization. It's very disorganized, but there isn't really a clear EKG or cardiac cycle. So with ventricular fibrillation, what we see is that the ventricle depolarization becomes erratic. What is like, I learned this like kind of analogy from one of my colleagues, and he said like it's kind of like the ventricles are having a seizure, and when you're having seizures, are you having coordinated movement? So you're having electrical activity resonating throughout the heart, but you're not actually getting real contractions because the electrical activity is so disorganized, the heart can't actually produce controlled and organized contractions. So the interesting thing about ventricular fibrillation is that the heart doesn't actually pump blood. The electrical activity is swirling around it, but because there is no coordinated contractions, you can't actually generate enough pressure to squeeze blood out and circulate. So this is why VFib is potentially deadly and eventually can lead to something we call cardiac arrest. So cardiac arrest is that stop in heart function. So This is deadly because, again, your heart is supposed to keep your blood circulating in your body throughout your life, right? So if your heart stops, that means you're not getting any circulation. So survival is important, intervention is important. And this is why time is critical if someone's in cardiac arrest. And this is why, to answer that previous question, why living on a high floor might be deadly to your health. Yeah, so it's not, so yeah, maybe also like if you take the elevator versus the stairs, but if you're like living in the 40th floor, that might not be feasible. But it was an interesting study was that they basically, these Canadian researchers, for everyone who had cardiac arrest and lived in one of these buildings, they asked them what, or they found out which floor they lived on. They did the statistics, and then it seems like, okay, like 4.2% survived discharge from the hospital. So it's already below the third floor. It's already pretty like slim chances you'll live. But 2.6% and above the 16th floor, yeah, not even just less than 1% survived. And above the 25th floor, where 30 people had cardiac arrest, none of them survived the cardiac arrest. So what we're seeing is that even just that elevator ride and that time in seconds just to get someone to get the gurney up and get it to the person and start CPR and then bring them down to the ambulance, well, all that time, it can result in there's some chance to survive to begin with, but yeah, nobody above 25th lives. So again, this is why cardiac arrest is super, but that's why it's also important to know this EKG and kind of recognize these signs and very deadly patterns like VFib, because you don't want someone ending up in cardiac arrest. Yeah, and so this is the original thing. Now, the thing is that, so the people who have, and the thing is like, even if you survive, are you going to return to normal? And the thing is that that's another, like you might see like in medical dramas, someone flatlines, they enter cardiac arrest, you do CPR, you give them epinephrine, they wake up and they're like, oh, what happened? Well, this is the reality. For people, most people don't survive. Like people on TV and movies, they survive way more often than in real life. And also they don't have the brain damage or other impairments or disabilities that they're often left with after entering cardiac arrest. So it's like, just because you survive cardiac arrest doesn't mean you're in the clear, because all that damage could happen to your brain while your circulation has stopped and your brain's being starved of oxygen and nutrients and accumulating all that waste. So yeah, that's why it's like very important to intervene. So if someone's is like, okay, what you do is like someone has like, they suddenly drop to the ground and then you notice they don't have a pulse. You want to start early CPR, and the first thing actually, before you even start CPR, call for help, because what if you're by yourself? Is it going to be easy to do CPR with one hand and then call 911 on the phone? What you do is tell someone else to call, start CPR if you're CPR certified, and if you're not, it's worth your time to get CPR certified. And yeah, so the thing is that even if you do CPR, I mean, looks like most patients survive their arrest, but the thing is that notice that the day after, some of them die as well. And even if you do CPR and you bring them back, out of all the admissions to the hospital, for surviving out of the hospital and leaving the hospital, less than 1/3 actually survive. So just showing you like CPR is important, but if the person dies, it's super sad, but don't take it personally, because again, it's very hard to keep someone, bring someone back from cardiac arrest. So if it's, as you see here, the chances are people tend to die more than they survive from this. So what you can also do is defibrillation, and then the post-resuscitation care that's handled by hospital. So defibrillators, that's what we have here, or here we have it en français. So same thing, but sounds very similar. But what are these? These are, you may have heard them called the paddles. They're going to deliver electrical shock. So or sometimes you also may have heard them called AEDs. That just means automated external. And what they do is deliver a huge charge. So remember that in terms of memory potentials, those are on millivolt scale. So that's 1,000th of a volt. This is going to deliver like 3 million times that. So it's crazy, yeah. But what we have here is like depolarized entire hearts, and most modern AEDs, they tell you exactly where to put it. And notice that it's like, okay, one on the upper right and one toward the lower left. And hey, that follows the conduction system of the heart, right? So what it does is try to stop those abnormal rhythms, and it's kind of just like doing a hard reset on your heart, like on your computer if it freezes up. That's what the defibrillation is trying to do. It's trying to shock everything, depolarize everything all at once, and hopefully your pacemaker cells take over to restore normal rhythm. Yeah. So what we see here is that this is why it's important and why they have this, because they want you to deliver that charge. And I heard anecdotally, well, I don't know if I want to mention that because I don't want anyone to try to experiment with that, but trust the placement, and supposedly it works in reverse too, but it doesn't matter. But the thing is that you want it to be along the conduction system of the heart. That's why you gotta know which way the heart points in your body. Yeah. Yeah, so depolarization is going to go that way, so this is why you want to make sure that follows the conduction system of the heart. Now what we have is that base of the heart, and this is where it's kind of weird with the anatomy of heart. They like whenever you hear the term apex used, they usually say like, oh, that's like the top or the point of something. The apex of the heart refers more to the point of it, the base meaning a wide area of it. So it's not that the base is on the bottom. In the heart, it's topsy-turvy. It's like an upside-down cone. The base is more superior. The apex is the point that's going more inferior and down to the left. Now, what we have is this. So this is why AED, and this is like, and it's ineffective on hearts that are completely stopped. And why is that? Well, if you have a heart that's completely flatlined and completely stopped, you don't have electrical activity. So just shocking somebody is not going to. You need some sort of electrical activity. If all the pacemaker and conducting cells are already dead, you can't shock them back into working again. So if the conduction system is already broken, you can't just jumpstart again with defibrillation. So it's like hot wiring a car where the wires have been cut. That won't work. So this is why I'm trying to talk about all this myth, because again, flatly-lying patients, you can try shock them all you want, but you can't, because if the conduction system is already gone, you can't just kickstart again. Yeah, for people with the sinus inversus and dextrocardia, yeah, so you have to actually place it in the opposite way. So that's why I think it's important if somebody find out later that you do have this condition, that you disclose it as well. Yeah, so this is what we mean by cardiac arrest, and notice that's completely flatlined as well. Cardiac output is, very briefly, what it is that very important heart rate multiplied by something called stroke volume. So cardiac output is a rate. So what it is the volume per minute. So basically, if you take 1 minute, how much blood is your heart pumping in 1 minute? How much is it squeezing throughout from one ventricle? So chronotropy refers to the heart rate, and again, when we talk about tachycardia and bradycardia. But what we see is that we have the heart, it's always beating through its autorhythmicity, but we also have modulation from sympathetic and parasympathetic nerves. So the cool thing about the parasympathetic and sympathetic system is that we have so this is why we spent all that time talking about these pacemaker potentials, is that these different branches of the autonomic nervous system, they can speed it up or slow it down. So sympathetic activity is going to increase your heart rate. By why? It's going to push the threshold, or push this depolarization and this prepotential faster. So that's going to shorten the time of these action potentials. So notice that you're cramming more of these depolarizations. So we're going to have a faster heart rate due to this increased pacemaker potentials. But with parasympathetic, notice that now it takes slower time to go to threshold. So now notice that there are fewer action potentials per the same amount of time in the previous examples. So this is why sympathetic activity is going to increase your heart rate, and parasympathetic is going to decrease the heart rate. It's all by modulating the activity of that SA node. Now, cardiac output, again, it's a rate, but what is heart rate multiplied by stroke volume. So what happens is, like, if you increase your heart rate, you're going to increase cardiac output. So if your heart rate is 60 and you go to 120, you're going to double your cardiac output. And say your heart rate is 60 or 100 and it drops to 50, you're going to reduce your cardiac output by half. So this is why it's a very useful formula. And we don't have time for a question because we're over time. So cardiac reserve. So the thing is that when you're at rest, your heart rate might be around 60-ish. But cardiac reserve is the difference between your maximum cardiac output and resting cardiac output. So if you've if you've like done exercise, or if you look at like some of those cardio machines, they talk about maximum heart rate as well. So if you go all the way to your maximum heart rate and then multiply it by the stroke volume, so that's the amount of blood you're pumping out with each beat. Well, that's what we have with your maximum cardiac output. So if you take that compared to your resting cardiac output, that is a big difference. So cardiac reserve, whenever you hear something called reserved in your physiology, it's how much more you can do something. So when you're at rest, you're not pumping out the maximum amount of blood you could potentially do. But if you're going full guns and you're now going to go to maximum heart rate and maximum stroke volume, that's your maximum cardiac reserve, or that's the maximum cardiac output. But the cardiac reserve is the difference between that. So what we have is stroke volume. Now let's talk about stroke volume. So volume, it is a volume, but it's the amount you do with every heartbeat. So that's what, but per ventricle. So when they're talking about cardiac output, they should be roughly the same in both sides of the heart. But when we're talking about this general function, usually they measure the left ventricle cardiac output. Why? Because again, the left ventricle does that very important job of pumping oxygenated blood to the rest of your body, right? So for the sake of simplicity, let's just talk about the left ventricle from this point on. So for stroke volume, that would be the amount of blood the left ventricle pumps out with every beat. So what we have are these two new numbers called EDV and ESV. Now we have to talk about cardiac volume. So stroke volume is the amount of blood pumped by each ventricle, and again we'll talk about the left ventricle for simplicity's sake. And this is how you calculate it. It's just the difference between two numbers. The end diastolic volume, so remember that diastolic is relaxation, right? So end meaning actually the end of that phase where the heart is relaxing and expanding. So this is actually going to be the maximum amount of blood in the ventricles after atrial systole. And sometimes it's also interchangeably used with the term preload. Now, in systolic volume, remember that systole is squeezing, right? So this is at when the systole is completely done, and now you have a minimum after this squeezing and systole. So the thing about that, when your heart squeezes, it's not going to squeeze completely flat where there's no volume altogether. Typically, there is a small amount of blood left in the ventricles, even though it's completely finished squeezing. You're still remember that the ventricles are also muscle cells, and they're going to have a hard time just pressing flat like a piece of paper that you're creasing into two. So how do you measure these volumes? So do you have to actually because if you're measuring like a cup or the volume in a cup, you can pour into another beaker, but are you going to do that with the heart? Well, fortunately, you don't have to do that. You can actually do something called an echocardiogram. Now, do not call this a ECG. ECG is reserved for electrocardiogram. Echocardiogram is sometimes just simply just called echo. So it's not ECG. ECG is electrocardiogram. Echocardiogram looks like this. So what we have here is like a cross section of the heart, and now we can see the atria, we can see the ventricles over here. So you can actually see the changes in the volume of the heart, and software can actually use the area and convert it to volume to calculate how much volume is in the heart when it's fully contracted and fully relaxed. Again, it's too fast for us to calculate visually as humans, but there is software that helps to calculate this end diastolic and systolic volume. Now, what you're going to do is basically take the difference between end diastolic volume when it's fully relaxed and end systolic volume. Because why? When systole happens, the heart walls are contracting, and then where does that extra blood go? It goes into, well, in the left ventricle, it's going to go up into the aorta, right? So what it is the difference between this volume over here and this volume over here. So again, it's not squeezing completely flat. There is some blood left over. So that difference is what we call the stroke volume. So what we do is like, where does that go? That goes up into aorta and now into circulation. So there's also something called ejection fraction, which is related to this. And what you do is basically what fraction of that blood left the ventricle. So compared to the initial amount you filled it with, how much of it were you actually able to pump out of the heart? So what it is basically you take the blood pump out in a beat, divide it by that total maximum amount you're filling it during diastole. So what you do is just take your stroke volume, divide it by end diastolic volume, and convert it to a percentage. Percentage is the standard units or scalar we use for ejection fraction. So the thing about ejection fraction, it's not going to be 100%. Why is that? Well, again, because if you look here in the stroke volume and the cardiac volume, is that we have a stroke volume is that we don't have complete ejection of all the blood that was in the ventricles, right? So this is why ejection fraction is not going to be 100% because you still have some stuff left over. But what we have here with ejection fraction is a rough estimate of how efficiently, so you're filling up the heart with a certain amount of volume, how much were you actually able to get out into circulation in the body? Now, so these are the main ones I want you to know for this class: end diastolic volume and systolic volume, volume, and ejection fractions. That's what I want you to know for this class. And I'll go over this very briefly. So there are things that can affect stroke volume. So stroke volume isn't always constant. The thing is that you actually need time to fill in the ventricles, but you also need strength to actually help squeeze it out and squeeze enough blood per cardiac cycle and beat so that you're actually able to get enough blood to everywhere else in the body. Now, there's something called preload, and preload is so it's actually a pretty tricky, complex concept, but what preload basically is like the more you fill the heart, the more harder it contracts. And why is that? Well, the thing is that this is a neat analogy that was given to me by my mentor. So what he did is like he said like, okay, it's kind of like if you're talking about the left ventricle, when you fill the left ventricle, it's kind of like a balloon in preload. So the more you fill in the balloon, the harder it's going to squeeze the air or water out if it's a water balloon. So here we have the balloon stretching, and it's stretching the cardiomyocytes. So the cardiomyocytes are going to, in response to this stretch, are actually going to contract. So the more you stretch a cardiomyocyte, the harder it contracts. So here we have say this is a normal contraction, but what we have here is that now we're filling up the left ventricle even more. So the interesting with this left ventricle now has increased volume. So increased volume is going to be here, and then with the increased volume, what is going to do is going to squeeze out and eject the stroke volume as well. So again, why is that? Well, the thing is that if you maintain that same stroke volume, you're actually filling now. Let's rewind a bit. So when you're filling up even more, if you have that same stroke volume, you're going to have leftover blood compared to the previous example. Thing is that your heart's main purpose is just to circulate blood. It's not meant to store blood for long term. So if you maintain that same stroke volume, but you're filling the ventricles with more and more blood, then the ventricles would start to have a lot of pressure and fill up with even more blood. So their ventricles want to get that extra blood that's being filled out by squeezing harder. So it's kind of like that balloon. So if you the more stretch the balloon, the more heart force it's going to force out of its little valve over there. Same with the heart. So the more you fill it up, the harder it contracts. That is what preload refers to. Afterload. So if this is the best analogy I could come up with. If you've seen in like sometimes football players, they use those little sleds as well. But if you've seen these weight sleds, what these people are doing is like they're pushing this weight, right? So what we have is this person is we're going to call them the heart. So the heart is a muscle, and they're using muscles to move weight that's providing resistance. Well, the thing is that when we talk about the vascular system, we'll talk more about resistance. But what causes resistance? It can depend on like the diameter of blood vessels. It can also depend on the pressures and how much blood is in all the vessels as well. So basically your heart has to push up against things and that are already there. It's not easy for the heart just to eject blood like there's ejecting it into space. Or think of it, another analogy is like if you're using a straw, it's easy to blow air through a straw, but what if you're blowing air from a straw into a drink? Notice that like blowing bubbles into like a drink is harder than if you blow bubbles into plain air, or blow through a straw into plain air, right? So same with afterloads. So more stuff that you have to push against, the harder it is and the harder you have to work. So this is the heart, say it's doing what's normal, this is our baseline is normal. Say you're adding more resistance and more pressure. So the heart now, to maintain the same cardiac output, it actually has to increase its stroke volume and increase its strength of contractions. So afterload is kind of like everything that's preventing the heart from doing its job. Now with normal ejection fraction, so I'll cover heart failure very quickly. So heart failure is actually pretty complex, and sometimes it's called congestive heart failure. And when you refer to congestive, like when you say like, oh, I feel all congested over here, like in my sinuses, you can think of it, it's like when your sinuses are all blocked up, right? Heart failure is kind of like when the heart is kind of blocked up and now it's not accumulating, not be able to actually pump blood efficiently enough to circulate to the rest of the body. Now it's not the same as cardiac arrest. So heart failure, so I like to think of it, now hopefully nobody fails this class and you study enough that you don't fail this class. But like it's like thinking of like failure with like 50% versus failure with a 0. Like cardiac arrest is failure with a 0. Heart failure is like doing it where you're not doing enough of that function, doing enough work to keep up. Same with heart failure. So it's a chronic condition, and symptoms, this is why it's also called congestive, because it can result in fluid imbalances. So fluid can accumulate in different parts of the body, and there are multiple subtypes like preserved ejection fraction, reduced ejection fraction. I don't expect you to know this for this class, but maybe when we get to the respiratory system we can talk about how what we have is something called pleural effusion. So now we get excess fluid around the lungs. You're going to also have fluid backing up into the lungs, because remember, the right ventricle is pumping blood and also fluid into your lungs, but you want to maintain that circulation. If that circulation slows and gets backed up, what if it gets that circulation gets backed up in your lungs? That fluid can stay in your lungs. Or what we have here is like swelling in the abdomen and ankles. So if you don't get enough blood flow to and from these areas, they might have accumulation of fluid in this area. So ejection fraction, so how much blood, so normal depends on your age, depends on multiple factors. So around 60 plus or minus 10 is about normal. But this is the thing with like borderline ejection fraction, if you're pumping out less blood with every beat, that is when you're saying, okay, what's happening? Well, now you're not having enough cardiac output. Maybe some of this stuff, the fluids are going to build up in your body as well. And reduced ejection fraction, yeah, this is when someone like say they have a myocardial infarction and they lose a lot of the cardiac muscle. Well, remember that dead cardiac muscle does not contract anymore. So this is why someone might have reduced ejection fraction, because their heart isn't doing full contractions. So this is one of the things that are considered in heart failure. So actually making a diagnosis of heart failure is more than just ejection fraction, but the overall arching theme is that you're not getting blood. The body needs blood, right? But now the heart isn't pumping out blood at a sufficient rate to supply the whole body. Okay, so AMP and BMP I might have to hold off until the next one because we're way over time. Okay, for those of you hung on, good job. Thanks for staying on. But again, not to add more to your plate, but this is all very important, especially if you're heading on into nursing and medicine as well.